Glad to have you back. We're on to session number 3.
And don't forget to post on social media using the hashtag Smatty25.
Great. Hello to you all, and thank you for being here. My name is Heather Evans. I am a white woman with jaw-length gray hair. Behind me is a purple and tan background. I will be your moderator for this session called Promoting Disability Inclusion in Healthcare, Employment Disparities, Mentorship, and Allyship for Workers with Disabilities. In this session, you will hear about 3 separate studies that speak to this theme. First, we will hear from Dr. Danby Lee at the University of Washington, followed by Dr. Kara Ayers at the University of Cincinnati, and then Drs. Heather Feldner at the University of Washington and Dr. Carly Friedman, also at the University of Washington. Each presenter will introduce themselves more fully at the start of their talk. After all the panelists have presented their work, we'll take questions and comments from the audience members. We would like to start our presentation with a very quick acknowledgement. So we begin by acknowledging that the lands on which we live and work are the ancestral homelands and traditional unceded territories of Indigenous peoples who've been here since time immemorial. The University of Washington acknowledges the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Squamish, Tulalip, and Muckleshoot nations. The Cincinnati area and the land that the University of Cincinnati has been built on is the native homeland of the indigenous Algonquin-speaking tribes, including the Delaware, Miami, and Shawnee tribes. And we honor with gratitude this land and the past and present and future of our indigenous family. Next, we are going to hear from Dr. Danby Lee. Danby, I'm going to hand it over to you.
Thank you. My name is Danby Lee. I'm using a she, her pronouns. I'm an associate professor in the Department of Rehab Medicine at University of Washington, also core faculty in Disability Studies and a faculty affiliate at the Center for Health Workforce Studies. I'm a middle-aged Asian woman with long black hair. I'm wearing an olive green top with black jacket, light brown framed glasses, and I'm using a purple background with University of Washington logos. So I'm going to talk about disparities in employment and work conditions among healthcare workers with disabilities. And I want to first acknowledge that this work was done through the University of Washington Health Workforce Studies Center. Bianca Frogner, Sam Pollock, and Sue Skillman were among the team members. So I think we all know the issue of ableism and structural barriers that individuals with disabilities are experiencing to get training and employment in the healthcare sector. Representation is important, and growing literature also highlights that greater inclusion can advance healthcare equity for disabled people. Also, with the ongoing health workforce shortages, supporting disabled people and entering and remaining in the workforce could serve as an untapped policy solution. In order to improve entry and retention, we need to know how they are represented within the workforce and also what their work conditions look like. But right now, there's only limited work-related data available for all healthcare occupations. Next slide, please. Sorry, I forgot to say that. So in this study, we aim to examine disability representation among different healthcare occupations and to compare differences in the employment status and work conditions between healthcare workers with and without disabilities. Next slide. We used the 2022 ACS data and included 2 samples. So all workers, which are 1.6 million data points. And so these include individuals 18 to 75 in the labor force. And the labor force in ACS includes both employed and unemployed individuals. because ACS defines unemployed as people actively looking for employment. And then we had close to 160,000 individuals who were in a healthcare occupation specifically. Next slide. So we included for sure the disability status variables. There are 6 questions in the ACS that includes vision, hearing, mobility, cognition, self-care, and independent living. And if you're not familiar with the questions, most of them are framed as having a serious difficulty in these areas. Next slide, please. So we categorized healthcare occupations into 8 categories, which includes physicians, advanced practice, and this was occupations diagnosing and treating in healthcare system, which included psychologists, PAs, occupational and physical therapists, but we excluded all registered nurses and created a separate category just for that, which also included APRNs. We had a therapist category, which included recreational or respiratory therapists, also therapist aides, technicians, which included dental hygienists, paramedics, lab technicians, and many more. Also LPNs and LVNs. There was a category of aides and assistants, which included home health aides, personal care aides, and CNAs. And then community health workers, which were mostly counselors in the community. Next slide, please. We also used minimum education requirements, which ranged from less than high school education to a doctorate degree. And then there were 10 healthcare settings that we included and categorized by home health, residential, so some long-term care settings, outpatient hospitals, and then medical offices of different types. Next slide. So to examine work conditions, we used variables like unemployment status, wage, work schedule, and work schedule included whether a person would arrive at work during standard hours, which was any time before 10 a.m., how many hours they work weekly, and also whether they work from home. And then we had these socio-demographic characteristics. We ran descriptive analyses and then weighted univariate and bivariate analyses to compare different groups. Next slide. So here are the findings. Overall, healthcare workers' disability prevalence was lower at 6.8% compared to 7.4% of all workers. And the difference was significant here. So we're seeing lower representation among healthcare workers. Next slide. When we looked at disability prevalence by occupations, education requirement, and settings, the highest prevalence was observed among aides and assistance groups at 9.9%, and groups like that require less than high school education and home health care settings. The lowest prevalence occurred among physicians at 2.6%, and within the group at highest education level, the doctorate degree, in settings such as hospital, physicians' offices, and dentist offices. So here we observed patterns in the prevalence where disability prevalence decreased as minimum educational requirement increased, and the disability prevalence was lower generally among settings that typically have a more rigid work environment, such as hospital settings. Next slide. When we looked at disability type, most prevalent types of disabilities were cognitive impairment and physical impairment, and this was consistent across all occupations except for physicians and advanced practice clinicians. And especially with physicians, they show 2 completely different categories of hearing and vision impairments. Next slide. The least prevalent types of disabilities were self-care and independent living difficulties. And also among those with disabilities, 26.5% had more than one disability. Next slide. So moving into work conditions among healthcare workers, 5.6% of disabled healthcare workers were unemployed, which is 2.7 times higher than the 2.1% among those without disabilities. While 5.6% is a high employment rate, the result also showed that healthcare workers have a lower unemployment rate than all workers with disabilities. Which suggests that maybe once individuals acquire the specialized skills and the credentials required in healthcare, they might be more likely to secure a job. But still, because of the skill sets and the high demand in healthcare, but still face many barriers to stay employed. We see a large discrepancy. Next slide, please. We see a large discrepancy in wages, where healthcare workers with disabilities earn about $45,000, which is about $22,000 less than those without disabilities. And this is 34% lower wage. And this may be due to the large proportion of disabled home care workers in lower wage occupations. However, literature has also shown that discrimination in general, underestimation of competency and productivity, the reduced negotiation power, and fewer promotion opportunities because of the lower productivity or part-time work contribute to these lower wages among people with disabilities. Next slide, please. In terms of work hours, healthcare or work conditions, when we look at work hours first, healthcare workers work about 2 hours less per week. They're more likely to work from home and part-time. Also, more disabled workers arrive at work during non-standard hours. And these findings can be, in a way, positive and negative. We definitely see more flexible work arrangements among people with disabilities, like working from home, which is good. However, we don't know if these numbers were driven by forced choices, where disabled workers didn't have options other than part-time work due to the lack of accommodations available to them. Also, what is not seen here is that there were significantly higher numbers of home-based workers among physicians, advanced practitioners, and aides and assistants, which are typically occupations that require an in-person interaction. And so it'd be interesting to explore these work arrangements and any employment supports if they were available. Next slide, please. We also found that home care workers with disabilities showed intersections between disability and other marginalized identities. Compared to those without disabilities, they were significantly older, more likely to be female, Black, and Hispanic, and more likely to have lower levels of education and socioeconomic status. These intersections suggest that employment disparities faced by this group are likely a result of systemic oppression based on their multiply marginalized identities. Next slide. So the study doesn't come without limitations. While we use this large national data set with occupation information, it is not designed as a health workforce study, so the data were limited to what we presented. Also, what I presented. Also, disability questions are framed narrowly as serious difficulty and may not fully capture the full spectrum of disabilities. Yet, this study provides a comprehensive analysis of disability prevalence and work conditions of healthcare workers with disabilities. And the main findings were that disability prevalence was lower among healthcare workers than all workers. And disability prevalence was also influenced by educational requirements and healthcare setting characteristics. And also that in terms of work conditions, healthcare workers with disabilities were more likely to have flexible schedules, but still face significant disparities in wages, job stability, and other work conditions. And all these findings really underscore the importance of a system level, a policy level change to increase entry and retention of people with disabilities. Also, we should consider the intersectionality of those with disabilities with other marginalized identities and should take them into account when planning these policy system level changes. Thank you. Oh, sorry, forgot to say. Next slide, please. Thank you.
Thank you, Dr. Lee, very much. Next, we will have a pre-recorded video from Dr. Kara Ayers.
Hi, my name is Dr. Kara Ayers, and I will be presenting Mentorship through a Disability Cultural Humility Lens, Transforming Healthcare Education from Within. I am so grateful for the organizers of SMATI and my co-presenters today that were understanding that I needed to present pre-recorded and virtually to you today. I had a family conflict arise that I could not miss for one of my kids, and so I just really appreciate being able to still share my information with you today. I don't have any disclosures that present a conflict of interest. I'm a salaried faculty member of Cincinnati Children's Hospital Medical Center, and on this slide have listed a couple of grants that fund my work. But again, I don't foresee any conflicts of interest today. So by way of introduction, this slide includes a photo of me in my power wheelchair. I also use a manual wheelchair, an attachment to my wheelchair. I'm fortunate to have different tools for mobility. I'm an associate professor, a researcher, and a psychologist. And a couple of the different programs that I'm involved in, I'm the associate director of our University Center for Excellence in Developmental Disabilities, or a UCED. And I also am grant funded through a project called the the National Center for Disability Equity and Intersectionality. And so those programs are relevant because sometimes I have the opportunity to connect our Disability Research Lab members to the work that we're doing, for example, through our UCED or through our National Center. And so we're going to be using the Disability Research Lab that myself and our lab members co-founded in 2020 as kind of a case study of disability cultural informed mentorship approaches. So this slide has a screenshot of one of our early Zoom meetings with the Disability Research Lab. Folks join from around the country and at times around the world. We've been in existence for 5 years now. At last count, our researchers include folks from around 30 different institutions, 5 different countries. We range from undergraduates to faculty members to lots of folks in between, including disabled researchers that aren't necessarily connected to an institution or a specific program at this time. Our only kind of requirements for the lab is that folks who join the lab identify as disabled and that they see themselves in some way or are interested in some way of being a researcher. We have some people that join our lab because they may be undergraduates and they think they're interested in research, but they're not sure. And then we have people that have been leading large research studies for many years. And of course, lots of people in between as well. Our lab has accomplished a lot in the last few years. We've provided feedback on accessibility feedback related to a research software startup company. We've defended multiple dissertations, translated research into easy read formats. There's an example of that on this slide that we did during the early days of COVID. We translated some research there into an infographic. We at one point had a writing accountability group. But what I think is most important to the work that we do is that we create a safe, welcoming, and disability affirming community where research and mentorship around that research can thrive. So we want our place to be one that people can come to with questions, with moments of vulnerability, with wanting authentic and open feedback to their ideas. We troubleshoot each other's accommodation needs and responses to accommodation needs from institutions. And we really just work to build each other up. So when there's calls for proposals, they get shared out with the group. And sometimes people will say, let's work on this together. And kind of like subgroups are formed as well. The group is multidisciplinary, but most seem to gravitate somewhere in the healthcare fields. And many of us also, in addition to being disabled, research disability as well. But that's not a requirement. We've also had folks from bench science fields that don't research disability necessarily or healthcare. One way that our approach to mentorship varies from a traditional hierarchical model is that we have more of an organic kind of network approach. We firmly believe that we can all learn from each other, not really related or tied to various like levels that we may have achieved. We know that traditional mentorship models can perpetuate ableist assumption and ideas. And what's really exciting about disability informed models is that they can not only benefit the mentor and mentee relationship, but we can also see positive benefits ripple out into provider and patient relationships, which is a nice kind of bonus, I guess, if we're primarily looking at mentorship right now. We also know that this disability informed mentorship model is relevant across multiple fields. So we know, psychology, medicine, rehab sciences, and more can all benefit from considering a more disability informed approach to mentorship. So I noted that we make a direct effort not to kind of impose a hierarchical mentorship approach. And ours, so on this slide, we have a visual representation more of a pyramid. That would be an example of hierarchical mentorship. We approach it more like this network or weaving a web of people where we think we can each learn from each other. We don't want anybody to kind of be on their own nodule on their own. So I would add even more lines to this if I were kind of drawing it to be even more accurate. But you can see that there's really no like top down structure with this. And part of our work aims to address the problems that we see in approaches to mentorship that are not disability informed. So we know all too well that ableist assumptions remain embedded in healthcare education. And I'm speaking healthcare broadly as various fields, including medicine, psychology, even social work. We could go down a list. So think broad with me. We also know that disability is unfortunately often viewed in a limited sense through only or primarily a medical model and within much of the curricula that guides programs in healthcare education. So we aim to address that limitation. We know there's limited spaces to talk about experiences of disability as a cultural experience or identity. So we aim to make a space for that. And we also talk openly about power dynamics in mentorship relationships that can unfortunately silence perspectives. After a particularly kind of enthusiastic discussion from our lab one day, where we talked a little bit about kind of the behind the scenes of healthcare education, which for disabled people can be pretty jarring to realize kind of what happens behind the scenes or, outside that patient's room when discussions of disability happen, especially when you yourself hold an identity as also being a disabled person. So after kind of an enthusiastic discussion about that with the lab, I entered some of our points of discussion into Dolly, I believe, was our platform that we use to create an AI generated image that shows us kind of the backstage of healthcare education. So we have on stage this patient doctor relationship that seems kind of traditional in what we might expect, but off stage or like behind the curtain is pulled back. We see things like medical expertise trumps lived experience. Disability means broken or deficient. Standard bodies require standard approaches. Success means overcoming disability, and independence, not interdependence, is always the goal. And then we have the director's chair there, which is labeled with some AI gobbledygook, but we talked about the director's chair being kind of like that hierarchical mentorship, and the chair is empty in this case because it just doesn't help. There's no director kind of in the seat to help guide what's going on stage versus off stage. So we, as a group, and I especially, I think, really appreciate kind of visual metaphors to think through some of these complex ideas. So this is one representation we wanted to share with you today. We also talk about integrating specific strategies to integrating disability cultural humility into our mentorship. And these are 4 that we do our best to integrate. So addressing those power imbalances in healthcare relationships. We always want to center lived experience of disability. We have an ongoing commitment to self-evaluation and critique, and we want to challenge the dominant narratives about normative bodies and minds. And so finally, I want to share 3 key dimensions to our mentorship model that drive our disability research lab. We have intersectional perspectives, practical strategies, and systemic impacts. So first, we are always trying to keep in mind intersectional perspectives. We're a cross-disability group. but we want to also be aware of specific and complex dynamics that are disability specific. We want to be flexible in our responses. Sometimes we have access conflicts. I know one interesting one that popped up fairly early in our work was we had lab members, we have deaf lab members who need ASL interpreters. And we also had a request from a lab member that said, spotlighting the ASL interpreter is really difficult for me to focus on other parts of the conversation due to my disability. So how can we be flexible to work out different screen options based on what you need and prefer to do your best work? And thankfully, with advancements of Zoom and everybody kind of chiming in to make platforms more flexible and more customizable, I think now we have that option. In the beginning, we didn't, and we needed to talk about the access conflicts that were at play. And in that case, we prioritized the access to language and talked about some other strategies. I think the person actually used a Post-it to block the ASL movement in that case. So we talk about intersections with other identities as well and power implications that play out in our lab that we want to be aware of. Practical strategies is an important piece of our lab that I didn't want to overlook as I shared it with you today. We talk about techniques for challenging internalized ableism when people take in those beliefs that disabled people are inferior or less than. We look at accessibility as foundational rather than an accommodation. We aim to provide an environment where there's bidirectional feedback mechanisms. Sometimes this is called reverse mentorship, but we don't even see it as there being a forward mentorship, just that hopefully bidirectional and multi-directional mentorship is happening among people from different backgrounds, identities, levels of attainment of their career so far, all of the above. We also want to model vulnerability and just not knowing or not knowing yet. So we don't have to know everything. This is a space where we can figure it out and we can say, I don't know, let's look into that and we'll get back to it. Here's another example of a practical strategy that we used a couple weeks ago in our disability research lab. This was just based on the idea of take what you need, kind of those like paper slips that sometimes you used to see outside of grocery stores tacked on the bulletin board, where just kind of a little morale booster where you take what you need. And so in our case, we asked members as they did their check-in for that day, what did you need? Do you need a break? Do you need support? Do you need more time, more resources, accommodations, or specific mentorship? So it allowed everybody kind of another unique opportunity to say, hey, I really need this. We can't always help with everything everybody needs. Our lab right now is not formally funded. Folks are spread out across the country, if not the world. So we're realistic about what we can provide. But sometimes people bring up something that they need, and someone in the lab, especially as we're growing larger and more diverse in who we are, can say, hey, I can help with that, and here's how I will. We also address systemic impacts, and we think about those in our work within the lab. So we think about effects that we may be able to have on healthcare education curricula. A few of us, including myself, have been invited to participate in some real needle-moving work, I think, to hopefully embed disability more effectively into more of our healthcare curricula. And so we provide updates on that type of work. We also want to see ripple effects beyond just our lab and our mentorship relationships. So that's exciting to think about. And it's exciting to think about what new research questions emerge once you have a disability-informed perspective. You stop kind of accepting things as status quo that are taught to us via ableism and start looking at the world through a different lens, which is exciting as a researcher. So I know I've mostly been speaking so far as a founder of the Disability Research Lab, thinking about disabled people as researchers or co-researchers, but we also know that inclusion of people with disabilities in research as participants just results in better science. So all of this results in better science, and we do a bit of that work in the lab as well, whether it be the scientist or the researcher having a disability and or the participants having disabilities. And to give another kind of practical example of what this looks like, in most cases, you can design research from a perspective of universal design, making it as accessible as possible for most people. Level 2, you can provide accommodations to adapt what you need. And level 3, which is more rare but sometimes necessary, modifications where you alter the standardization process. So we dig a little bit into that as well, with the goal to include more disability perspectives in research overall. So what's next for us? We continue to apply for funding. We continue to recruit and mentor, and that's not easy, as I know many of you are familiar in these current times. But as this little adorable possum in a trash can on fire says, the horrors persist, but so do I. And so will our Disability Research Lab, as long as I can keep it going. So we would love to have you join us. You can email me at kara.ayers@cchmc.org. You can also find me on X occasionally, Blue Sky, and Insta at Dr. Kara Ayers. And I would love to discuss with you your thoughts around disability-informed mentorship. So send me a message, come join our lab, and I hope you have a wonderful conference. Again, thank you so much for letting me be here in this accessible and inclusive format for me today. Have a great afternoon.
Thank you. We're so glad that Dr. Ayers could join us even in the pre-recorded format. So the final presentation of this session discusses research that I am honored to have conducted with my exceptional colleagues, Drs. Feldner and Friedman. This research is titled Moving the Needle and Watching It Get Stuck: Mixed Results from Piloting Disability Allyship Modules in Health Professions, Education, and Beyond. So I briefly introduced myself, but to round that out, I am an assistant professor at the University of Washington and am currently the director of the Disability Studies program there. I am a cisgender woman and identify as multiply disabled, having a chronic illness and a mental disorder, both of which manifest in a variety of differences in the way that I function. Most directly, I also identify as CRIP. And I will turn it over to my colleague Carly to introduce herself.
Hi, everyone. I'm Carly Friedman. I'm the Director of Research at the Council on Quality and Leadership. My pronouns are she and her, and I'm a white, non-disabled woman with brown shoulder-length hair. I'm wearing a white button-down shirt that has pink bicycles on it and also wearing clear glasses, and the background behind me is white.
And my name is Heather Feldner. I am an associate professor in the Department of Rehabilitation Medicine at the University of Washington, and also a core faculty member in the Disability Studies program. I am a cisgendered white woman. I have long brown and silver hair. I have bright blue rimmed glasses on, and today I'm wearing a green shirt that says Disability is Diversity, and a white blazer, and my background is purple. And we have no conflicts of interest to report. And there is a 4-panel image on this screen of a variety of accessibility symbols, including a wheelchair symbol, the outline of a person's head and brain, hands that are engaged in signing, and a person walking with a white cane. Next slide, please. So I wanted to start today by outlining the framework that we've created and used as a foundation in our education and research work. And theory can often be a little bit nebulous in translation to practice. So we aimed to create a concrete framing of how we're using critical disability studies to inform our allyship work in healthcare education and practice. And this figure on the screen is one that we designed and kind of keep coming back to in our various projects. It's a large purple circle ringed with a variety of accessibility icons and bullet points of the core tenets that we use to frame our work. And these tenets include recognizing disability as a complex relational and social construct, political identity, and culture. Acknowledging that ableism is everywhere and contributes to inequitable access, including healthcare. Accepting that experiences of body-mind, social barriers, and systemic oppression all matter and shape the disability experience. Naming that our main goal is access and representation, justice and equity, and care for and about all bodies. And recognizing that disability must be examined from critical and intersectional lenses that include feminist, queer, and race theories. Next slide, please. So what is the evidence landscape of healthcare provider bias? Well, we know from previous literature that explicit bias tends to vary, but also be lower among health profession students, as well as improve over time through health professions education. However, literature does note and point out that discipline-specific differences in explicit bias levels have been pointed out. For example, PT students have been shown in some cases to have less favorable attitudes toward disabled people compared to their counterparts in OT. Next slide, please. So when we look at implicit bias, however, research indicates that healthcare profession students tend to have similar and similarly high levels of implicit bias, and this tends to remain stable throughout the educational process. Many providers believe that they're not biased despite consistent differences in clinical interactions with disabled people, which speaks to the impact of this implicit disability bias. Overall, however, there are fewer ways to measure implicit bias, and as a result, there's much less research on this in healthcare professions compared to the work that we have to examine explicit biases. Next slide, please. And from Carly's work, we see that there's a complex relationship between explicit and implicit attitudes toward disability, and we know that this impacts healthcare practice and policy. Most people tend to have lower or neutral explicit attitudes combined with high implicit bias toward disability. And so this means that consciously we may claim to treat disabled people fairly or show no bias, but unconsciously we still hold negative prejudices that can lead to assumptions about things like quality of life. Communication issues. It can lead to delayed or denied care, diagnostic overshadowing, exclusion or lack of consideration from certain treatment protocols, as well as microaggressions and mistrust. We know that these outcomes of this combination of explicit and implicit bias are a significant contributing factor to health disparities within the disability community. Next slide, please. We have seen this at an institutional level as well. Evans and I had the honor of leading a qualitative study examining the experiences of ableism, allyship, and healthcare access at the University of Washington. And we engaged with 22 students, staff, and faculty, all of whom identified as disabled or with a chronic health condition, and a third of whom were people of color. And our data highlighted experiences of ableism and allyship at individual, at group, and at institutional levels. And four main themes emerged from this work. First, experiences of ableism were ever present in healthcare. Next, that ableism co-occurred at the intersections of gender and race. Third, that the COVID pandemic both surfaced ableist practices, but also led to greater access for disabled people who had been advocating for decades for flexible policies and remote work opportunities. And finally, that disability allyship and healthcare partnership building was really grounded in provider recognition of disabled people's expertise in their own lives and health conditions, communication and listening, and resisting assumptions. Next slide.
Thank you, Dr. Feldner. This is Heather Evans, the other Heather of our team, speaking. So as Dr. Feldner just discussed, our results pointed to the benefit of allyship, but also to a gap in deep understandings of what disability allyship looks like in healthcare spaces. So to fill this gap, we developed a disability allyship curriculum for healthcare professionals, drawing both on our own work collectively and our colleagues, as well as the work of others, such as the image shown on this slide taken from the CDC or the Center for Disease Control. The word ally is spelled out with further elaboration on each letter. The letter A prompts us to acknowledge and respect individual experiences and abilities. L encourages us to learn about different disability types. The second L urges to leverage your influence to promote accessibility and inclusion and eliminate barriers. And then Y reminds us to yield the floor to people with disabilities so that they can also identify and provide the means to eliminate barriers. So these tenets, fleshed out by our critical disability studies framework that Dr. Feldner just described, really form the basis of a bespoke education module developed for this study. And so that brings us to the most recent study in which we designed a mixed methods pilot that included a two-phase education module development and then evaluation plan. So we decided to develop really two versions of this allyship curriculum, one for general education and the other for healthcare education audiences. Working very closely with Dr. Friedman, we pulled from a variety of tools that measure both implicit and explicit attitudes toward disability as a way to capture or measure potentially differences in bias. Our small pilot used two formats. One format consisted of a single 2-hour long, fairly intense session of content delivery and discussion. And then we also had the opportunity to infuse the same content into two different courses that were taught over the span of 11 weeks. So at the University of Washington, we're on the quarter system. Those of you on the quarter system know that is both a blessing and a curse in many ways, but we were glad to have the opportunity to be able to try this other format of delivering this education module. So to measure the impacts of the curriculum modules, we administered pre and post surveys that contained demographic questions of each respondent, also questions from the Disability Attitude Implicit Association Test, questions from the Attitude Toward Disabled Persons scale, and the Symbolic Ableism scale, a scale developed by Dr. Friedman and her colleagues. So, in addition, we conducted small focus groups with folks after the workshops to get feedback in their own words on the curriculum, on things that they thought maybe were missing, or what seemed to really stand out to them most. So, the heartening news is that with exposure to our allyship curriculum, that did seem to appear to be statistically significantly associated with an increase in participants' positive attitudes towards disabled people. On this slide, we present a bar graph displaying participants' pre and post scores on the Attitude Towards Disabled Persons, ATDP, scale that we used of the 2-hour workshops, the first and the second course. So scores for workshop participants overall increased from 82.4 to 85.4, or basically a 3-point increase. Scores for the first course participants increased from 84.7 to 93.6, or an 8.9-point increase. And scores for course 2 participants increased from about 81 to 85, or about a 4-point increase. So again, what we see is a significant but relatively small improvement in explicit disability bias with these scores. However, we saw no significant change in implicit bias after exposure to our curriculum, whether that was presented as a one-time workshop or over a full quarter. That is, there was simply no statistically significant change in participants' symbolic ableism scales, nor in their implicit attitudes. So thus, as our title foreshadowed, we saw the needle move a bit through this process, and then we really saw it get stuck. But both of our findings, one, that it is possible to change explicit bias through education exposure, and two, that it is demonstrably harder to unseat implicit bias, both of these findings are really consistent with prior research in this area. We are still in the process of thinking through what the full implications are of these results of our initial pilot study. One possible interpretation is that as people become more aware of, perhaps develop more facility even with articulating disability allyship and with identifying disability bias, that as that increases on that explicit level, it might be that those same individuals perhaps um, maybe even feel a little less like they need to do the harder work of engaging in recognizing and uprooting those deep unconscious biases. Or it could be that with renewed language and a better understanding of the concepts of disability allyship, that folks are simply better at potentially masking some of the deep implicit disability biases that they hold. So we've also not fully really dug into systematically analyzing the qualitative data that we collected from focus groups. And so we do anticipate finding more clues here on where to take these findings in the next step. And in conclusion, really, we're interested in your thoughts on where we go from here. And that applies to all three of our presentations. As we saw with Dr. Danby Lee's work, we still need to do some critical work on structural barriers to make sure that we increase, at least to parity, the number of healthcare workers who themselves have disabilities. We heard from Dr. Ayers and the success of their mentorship model of disabled healthcare workers and students, including students, mentoring each other along the way and the benefits of having that participation. And then we saw in our own study that by leveraging much of this information gathered from our colleagues, we can move the needle a little bit on, again, explicit bias in the healthcare profession, but we still are encountering those barriers of moving the needle in a meaningful way when it comes to implicit bias. So on behalf of all three of the presentation panelists that are here, we thank you for attending our session, and we have a short time left that we would like to welcome any questions or comments. So this is Heather Evans speaking. I am looking at some of the questions that have come in, and one of the most recent was, how were we able to have our course included in the training curriculum? And this is regarding the last presentation, the third presentation. Heather Feldner, I'm going to invite you to respond to this.
Sure thing. This is Feldner speaking. And I did put a written comment in the Slido as well. But both Evans and myself teach disability and health related content or courses, whether those be elective or core courses. And so we were able to use the curriculum material in our own courses, kind of spread out throughout more of that quarter-long format. So it was fairly straightforward for us since we were actively teaching that type of content in our courses at the time.
Yes, thank you for that. I'm going through some of the questions. I want to emphasize that the conference materials are available on the website. I also wanted to highlight a comment from Dr. Lewis Andrew, who says there's something else that I call, quote, adverse mentoring. And it's when you see deplorable behavior and make a conscious choice to do the opposite. I'm just announcing now that I am stealing your concept of adverse mentoring, and we will be incorporating that probably into our own allyship training. I also wanted to address the question that asked that was what instructional methods were used in the interventions. And by instructional methods, I assume that what's being asked here is, how did we deliver the content? And for Dr. Feldner and I, we tried to be to present the content in multimodal, different ways of talking using both citing research, telling personal stories, using images, videos, clips. We really tried to maximize our pedagogical toolkit in conveying this information. And then the main comparison was doing it in an intense workshop setting versus spreading it out over the 2 courses. This is Evan speaking. I also want to encourage other panelists to chime in as I am perusing questions that came in as well, if you have questions for each other.
There was a comment in the Slido for Danby in regard to dietitians being included in your study. If you wanted to comment on that. I saw you responded in the chat, but maybe can comment verbally as well.
Yeah, sure. And thanks for catching that in the question. So yeah, as I mentioned, the examples I mentioned were just a few of the many healthcare occupations included. We have a full table just listing all the different occupations categorized into those 8 categories. So yeah, dietitians are part of it. I'm actually looking at the list right now, and those, like, we have chiropractors, podiatrists, audiologists, speech language pathologists. All of them were included, and they were part of the advanced practitioner groups. And then, yeah, dental assistants under aides and assistants. So you can think of it as a very comprehensive list of occupations categorized into those 8 groups. So yeah, thanks for letting me talk about that and highlight that one more time.
There are a number, this is Evan speaking, there are a number of comments asking questions about the differences between PT versus OT. I think this is to you, Dr. Feldner and Dr. Friedman, and how much of their training is identical. However, OTs seem to embrace a social model of disability with practical emphasis, while PTs apparently embrace the medical model. And I'm wondering if you would like to speak to that.
Sure. This is Feldner speaking. Yeah, I think we see in both the research literature and just in terms of like anecdotally being in a PT program that works closely with an OT program. And Danby can speak to this as well. I think OT as a profession has just tended to embrace a little bit more of that kind of social or relational model of disability earlier than, I think we're just starting to kind of see that happen in PT curricula. And we're working actively to kind of chip away at that and change that a little bit. As one example, from the PT side of things, the course one of the courses that I teach, Disability and Health, is kind of exploring disability and health from that critical disability studies perspective. And that started out as an elective. That's how I kind of had to sell it to our leadership, and it was really well received. In the last 2 or 3 to 4 years that we've been doing that course as an elective, there's been a really positive response to that from students. Students across all disciplines are asking for more of that content, and earlier in their programs, across the board. That plus some new kind of requirements from our accreditation body really have led the conversation and led us to push for that course content to be integrated as a required course, particularly for the physical therapy students. So it's a work in progress, but we do know that there's that kind of large difference in curricular history and kind of current practice that really focuses more on that medical model approach in PT, unfortunately. Danby, I don't know if you want to add to that as well, or.
Yeah, and I can speak to the OT field. So occupational therapy definitely takes more into account the environmental impact on people, because we think about life and do more holistic approach where we think about how does environment impact you. And so sometimes it's seen as, okay, we're thinking about the social model, but I think there's still this underlying understanding or focus on the biomedical approach in terms of addressing impairment and, you know, fixing, quote unquote, fixing or rehabilitating our patients slash clients. So yeah, I mean, there's definitely, we see a not positive generational change. More like the students that are joining us come with the understanding of the social model, want to learn about the social justice aspect and, you know, critical disability studies, and we teach them about that much more. But there are a lot of practitioners out there that are still operating based on the medical, you know, biomedical approach and focus on that. So on a national level, on an organizational level, from the, you know, OT Association, there's still a lot of work to be done to kind of change the culture of the whole field, I would say. But yeah, work in progress, but there's still a lot of room for improvement.
Thank you. This is Evan speaking. There are 2 points that I want to address that have just come up in the questions. One is, have you studied medical education administration biases that may adversely affect student education access? Have you researched ways to address that problem, considering the power differential between admin and students with disabilities? Which I think is a brilliant idea for another potential research direction. But I want to turn to the three of you to see if, are you familiar with any work specifically that is examining biases among medical education administration? I see Dr. Friedman shaking her head no.
Yeah, this is Carly. I am not familiar, but I agree. That sounds like a great and important direction.
Yeah, this is Feldner speaking. I agree. I don't think that I can't think of anything off the top of my head. Outside of, we are conducting a study right now, and actually, Carly and Evans are both involved in this study. We're looking at provider attitudes toward disability and how that might relate to self-reported patient outcomes for people undergoing an episode of care in rehabilitation. Now, this is focused more on the provider side of things. But I will say that many of our providers at UW in particular are also administrators of curricula and programming. And so we might have a little bit better of an understanding of that, you know, if we can complete the study as planned. And so hopefully we'll have a little bit more to add from that administrative level for those people that kind of take on dual roles.
Thank you. I note that someone commented that that question alone could be an entire conference, which I appreciate. See you all here next year. We've only got 1 more minute, and I did want to address very briefly, there was a comment of, what can we do to force medical schools like the School of Medicine at UW to adopt a social model perspective? And I just very briefly wanted to make a little bit of to provide a little bit of pushback even against the idea of getting everyone to adopt one perspective, particularly the social model of disability. Just from a critical disability studies perspective, sharing with our audience and reminding us that the social model of disability is really a model that was generated in the early 80s, really hit academia in the early 90s, and that there is a lot of work out there that continues to build on the social model, expand it, make it more inclusive, and complicate it in real messy, intersectional, and more realistic ways. And so I think that even within our schools of medicine, it's important to keep up with the research and the theory in our sister fields and make sure that we are adapting the more complex, more realistic perspectives of what it's like to live with a disability and what it's like to navigate and work in healthcare spaces with disabilities. And with that, I believe I have just taken us over time. Thank you all so much. And I just want to echo the note that, boy, I hope someone's saving all this chat somewhere because there is a lot of good information being shared. Thank you.